Hello, everyone. Welcome back to the Indian Journal of Anesthesia podcast. I am Dr. Karthik Dr, your host for today. I am thrilled to have you all join with us as we explore three exciting research articles with three amazing authors from the December issue of IJA. Or should we call it the Christmas or New Year issue? Well, I think we should call it as a winter issue with the temperatures getting low now. I'm especially excited to introduce my co host, Dr. Poornima, who is joining us for the very first time. Dr. Poornima is currently working in the Department of Anesthesia at the Apollo Hospitals, Bangalore. I'm sure she'll bring a lot of depth and energy to our discussion. Welcome, Dr. Poornima.
Thank you, Dr. Karthik, and also thank you, Dr. Rakesh and Dr. Gayatri and Dr. Murli. I'm very excited to be here, very thrilled to be joining this podcast journey along with you all, and looking to build upon this. Thank you so much.
All right. Now, let me pass on the mic to the host of the hosts, Dr. Gayatri, to proceed further.
Thank you, Karthik. Friends, as always, we're going to start off with our very own editor-in-chief, Dr. Rakesh Garg. Dr. Rakesh, welcome to the podcast yet again.
Thank you so much, ma'am. And thank you, Karthik, Poornima, for taking this podcast to all the readership of Indian Journal of Anesthesia.
So, Dr. Rakesh, as we were discussing the other day, the next issue, the January issue of the Indian Journal of Anesthesia, will focus on meta-analysis and systematic reviews, is it not?
Absolutely. I think when we say the evidence-based medicine, we are looking for some studies which give some concluding statement to change our clinical practice. And in this hierarchy, the systematic review and meta-analysis lies. And IJA proudly announces, probably through Gayatri Madam, that it will be having an exclusive issue of articles related to systematic review and meta-analysis as the opening issues for 2025.
That's wonderful, Dr. Rakesh. And I was thinking after a conversation the other day when I heard about this, I said, as a prelude, I thought, why not quiz you on an essential aspect of meta-analysis? We've always in medical research put meta-analysis on a pedestal as a gold standard for evidence. And for years, we have focused on statistical significance and effect sizes without stopping to ask, do we have enough data to make reliable conclusions? And I understand that trial sequential analysis is what, comes in as an answer to that question. So I'd like to quiz you a little about trial sequence analysis. So what is TSA or trial sequence
analysis?
analysis?
This means today is my examination and my examiner is Gayatri today, is it?
No, I feel I am the probably I'm the examinee asking the examiner for a answer to a question that I don't know.
So, okay, let's start.
So, so the first question is, what is trial sequential analysis and why is it used?
Right. I think when we talk about any research, we use a lot of assumptions, we lot of predictions, and all the research are based on these predefined assumptions. And this help us to use some statistical tool. So statistical tool is an important armamentarium in the life of a researcher, and it also gives good conclusion for whatever we do. So trial sequential analysis is one of the statistical tool, basically that strengthens the you can say the data that we collect through systematic reviews. We synthesize data and increases the reliability of conclusions. This is as similar as when we do a randomized controlled trial and we put certain values into this and we say that we can conclude something from the primary objective if this number of patients are included into the study for analysis. So same probably would be for systematic review meta-analysis. This is one of the type of study. So we have to put in something into the meta-analysis to say that the outcome or the conclusion from this meta-analysis is sufficient enough to conclude something. And this is, again, I will just try to relate with the randomized control trial where we often talk of type 1 errors, type 2 errors. Sometimes we put limitation there that the sample size is small. And if we add on the meta-analysis aspect, where it is combination of the data from multiple studies, there would be something heterogeneity into the data collection, or there will be repeated testing when new studies are being added on. So when we incorporate all those things, type 1 error, type 2 error, the risk of heterogeneity, the sample size in an individual study, repeated testing, as the cumulative studies comes into the publications, these are often the risk factors for making some conclusion from the meta-analysis. So now we have some risk factors. As we do for RCT, we try to reduce those risk factors. And this is where we addresses the trial sequential analysis. Similar, I think, Gayatri, you must have heard something into the clinical trials also. There's something called interim analysis. When we do study for a particular, say, a new drug, and we're looking for either the benefit or sometimes even harm also, we always introduce something called interim analysis, wherein, and this is a priori decided. And when we say that our threshold for that harm or benefit is reached, we can stop the study. Same principle comes for the trial sequential analysis also. So this is basically an interim analysis of a meta-analysis. I'm just saying in a very gross term. So it addresses the risk of random errors. It nullifies the overestimation of whatever the primary objective of trial sequential analysis is, whether those studies are small sample sizes, error I've just mentioned about. So this will all try to nullify those things, reduces the likelihood of false positives and false negatives from the data that we have collected. And it just ensures that whatever we are concluding is based on the data that we have collected from multiple studies and synthesized into this meta-analysis. So this is in brief when we talk about trial sequential analysis, and you asked that why do we want to use it? So we use it for making a definite conclusion out of the analysis that we do for meta-analysis.
So, from what you've said, I have understood probably that a trial sequential analysis kind of gives a little bit of something like a sample size to make sure that whatever we're getting from the meta-analysis can be concluded reliably. And then you also mentioned that it gives, at a level, when you reach a level, you can actually stop doing the trial so that you're not unnecessarily wasting time and resources by doing it beyond what the numbers required are. Is that right?
Absolutely.
Yes. All right. And so if this was so essential for a meta-analysis to be reliably concluded, why don't more researchers use TSA in their studies?
So I think this is as simple as that. We see now that the mind sees or the eye sees what the mind knows. So sometimes we have to introduce. So even in the research, if you see in last couple of years, some advancement has been done to use those tools. And now these tools are available. So I think we have talked, Gayatri, in the last few with you and Dr. Murli also about the use of confidence interval. So probably say 10 years back, 20 years back, we were okay with p-value, but we understood that p-value has its limitation, and this limitation to a certain extent can be taken care by confidence interval. Same thing when we say meta-analysis. Yes, there were meta-analysis where we were able to conclude something, but then when somebody did a meta-analysis, say 5 years later, with more studies added to it, sometimes the conclusion changes. So this means the previous meta-analysis has certain limitation. So understanding those aspects, now we realize that even if I do meta-analysis today, I should be having some tool to say that the number of participants in this meta-analysis or vis-a-vis the number of studies with participants are sufficient enough to make some conclusion. So we have understood this concept now. And that's why if you see the recent meta-analysis, and I'm happy that IJA is publishing those now, and even we are asking authors to do it so that we can say that this particular objective is having a concluding statement. And now no more studies probably will be required for this. We can change our clinical practice and benefit our patient.
So, having said that, I want to ask you, what do you think is the most common mistake researchers make when using TSA? Or is it too early to talk about it?
I think let's start using it. But absolutely, I think when we get something new, we also have to understand that we are not disusing it or misusing it to a certain sense. Now, in research, there is one important aspect. We make certain assumptions, and everything does not come through statistical tool. We have to apply the clinical knowledge to it. Now, when I say that, say a particular drug A is giving certain benefit and I'm comparing the drug B. Now, how much harm will be acceptable to me, because all drugs will have some effect on it. If some drugs case just causes say nausea, vomiting, which is manageable, may be acceptable. If a drug causes similar incidence of seizures or myoclonus, probably that will not be acceptable. So this means we have to have some assumptions, acceptance that this much of margin is acceptable to us, because we use sometimes a terminology called required information size or the sample size that we talk about. And we also use the Z curves for TSAs. So we have to set a margin that this margin probably is acceptable to me, and beyond this margin, whether harm or benefit, depending upon what the objective is not acceptable to me. So this means we will be making these assumptions based on clinical findings. It may be differing for different persons. So that's why interpretation should be appropriate. We should not be interpreting it. And sometimes we try to, as I earlier mentioned also for randomized controlled trials, we do a lot of subgroup analysis and with secondary objectives. So again, that can be done for the systematic review and meta-analysis also. So we should be cautious that we should be applying the subgroup analysis more cautiously, because they may be underpowered. There may be a lot of heterogeneity because they may not be the primary objective though for those particular studies. So these are the small things that we should not overinterpret the values that are received from TSAs to make some conclusion. So we should be wiser that these are just directionality of some harm or benefit, but we may not be able to make conclusion for each and everything, because the statistical tool will give us values. Interpretation, we have to do it on the background of what the objective was.
Yeah, I think when you said when you were talking about this, what came to my mind was there's a very lovely article on actually a commentary on trial sequence analysis in the current issue of IJA. I request all the listeners to actually go out and read that, because it's kind of makes it easier to understand what Dr. Rakesh is talking about. And it says that as a disadvantage, sometimes the trial sequence analysis could be a conservative approach, and sometimes a potential beneficial effect of a treatment may be missed out. So I think you've kind of covered what that said. Now, do you see TSA becoming a standard requirement for meta-analysis in the future?
I think change comes slowly, but IJ has adopted it. The scientists are getting it. We have the softwares available that are making this analysis better. There have been a lot of commentaries, and I do not know whether I should release it, but there will be a little interesting reviews from the experts in the January issue that will simplify not only the application of TSAs, but how to interpret them. And IJ will have some surprise articles in year 2025 and a couple of good articles which talks about TSAs. So I'm sure that it will become an essential component of it. Though if you see the PRISMA guidelines, which dictates the reporting of systematic review and meta-analysis, they do talk about TSAs. So once we understand more, we'll start using them and we'll give you more concluding statement. And I'm sure that 2025 will see more of TSAs in all meta-analysis.
Thank you very much, Dr. Rakesh, for clearing my doubts as the examiner. And I'm going to hand over to Karthik now, because we're going to start off with our articles for this episode.
Thank you so much. And I'm sure that, again, these articles will give you more insight. And we have popular and wonderful researchers today on board on this podcast. Thank you, and over to you.
All right. So without further ado, let's get started with our first article for today, which is Relationship of Lung Ultrasound Score with Oxygenation and Pulmonary Mechanics in Mechanically Ventilated Patients. This was an observational study by Dr. Nishant Kumar, who is a professor, Department of Anesthesiology and Critical Care at Lady Harding Medical College, New Delhi. Welcome, Dr. Nishant.
Good evening, everyone, and thank you for having me here.
So, to begin with, Dr. Nishant, we would like to know what lung ultrasound score is, obviously, and what prompted you to explore the correlation between lung ultrasound score, oxygenation, and pulmonary mechanics, especially in the mechanically ventilated patient.
Okay, so when we talk about critical care, we obviously like a lot of scores. We like to know the prognostication. We want to know the morbidity. We want to know the mortality. So lung ultrasound score was devised based on the picture that you get when you do a ultrasound scan of the lung, and you see the lung as a whole, bilateral lung as a whole, and then you obviously assign the score based on the severity of the disease, and on the basis of that disease, you can assess how much the lung is involved and what is the morbidity and mortality. So the basis of this study was basically we came across a lot of studies using lung ultrasound and lung ultrasound scoring to project to prognosticate and to project the morbidity and mortality in ARDS patients and other critically ill patients. Now, what got me thinking was we have this particular score which predicts the morbidity and mortality. Now, when we are ventilating these patients of ARDS, the one thing that we aim at is oxygenation. True. So, I was surprised to find that there were no studies which had this basic information whether the lung ultrasound score or the presence of B lines that we see on the lung ultrasound actually correlate with oxygenation or not. So that was that got me thinking. And then most of these patients are mechanically ventilated. So I wanted to know whether the mechanical ventilation would alter these B lines, because obviously we know as we apply PEEP, the oxygenation increases. But then as the resistance increases, as the compliance decreases, do these B lines change, or is there a correlation, or is there a relationship between them as well? So this was a very basic question that I asked, that whether these B lines that we are counting through lung ultrasound, they actually have a relationship. We are prognosticating, we are making these scores, but do they actually predict something, or we are just, assuming that they do? So that is what was the basis. And fortunately, we found that obviously they correlate with the oxygenation. However, the correlation with the pulmonary mechanics was not that very strong, and we could not replicate it. The R square was moderate to say. So yes, but with oxygenation, we are sure that as the number of B lines increase, the oxygenation is going to be worse in those lungs.
Thank you for breaking that down for all of us. Now, could you briefly explain to us what the 12-region lung ultrasound method is and how does it differ from the 6-point lung ultrasound method? We have seen the 12-region lung ultrasound method in your study. Can you briefly explain about that?
So basically, lung ultrasound originated with the Blue protocol. Now, this was introduced. Obviously, we don't have X-rays, portable X-rays. Then developing the film takes time. So, Blue ultrasound, the Blue protocol, as it is said, bedside lung ultrasound in emergency, it's just a quick way of assessing what kind of lung disease or the cause of respiratory distress in a patient is. So basically, 6-point means 3 on each side. So basically, you examine just 3 points on each side of the lung, and you decide whether it's a consolidation, whether there's a pneumothorax, or whether there is any other pathology in the lung. Now, once a patient is shifted to the critical care, the 12-region method has been used to replace the X-ray and CT. Now, there have been studies which have shown that lung ultrasound, if not better, gives you the same information as an X-ray chest, sometimes earlier than the X-ray chest, because the changes on X-ray chest appear later, and almost equivalent to a CT, if not better. So the 12-point ultrasound is basically we divide each lung into 6 points. So we have the anterior, lateral, and the posterior parts, and then divide into superior and inferior. So the landmarks are very simple. The superior and inferior are divided by the intermammary line, the line passing through the nipples, and then we have the anterior, which is from the sternum to the anterior axillary line, the lateral from the anterior axillary line to the posterior axillary line, and the posterior part of the lung, which is from the posterior axillary line to the lateral border of scapula. So basically, you're scanning the whole lung on each side, 6 regions on each side. So that gives you the 12-point score. And you see the maximum number of B lines that you see and award a score on each region. So in each of these 6 regions, so you have the 12 regions, and therefore you derive at a score. So on the basis of that, you derive the lung ultrasound score, and more the score, worse the outcome and worse the diseases, the more severe the diseases.
Speaking of which, so do you compare the lung ultrasound score with a chest X-ray? Like, what is the comparison between both of them, and how do you see lung ultrasound better than routine chest X-ray?
Uh, there are certain features which you can see earlier on an ultrasound, like the X-ray chest may appear absolutely normal, but you can pick up subpleural consolidations. And as I said, the number of B lines, the edema which is there, interstitial edema, or even alveolar edema, which might appear much later, or if a much larger area is involved on X-ray chest. But with ultrasound, yes, you're scanning each and every intercostal space, and then you can easily find it much earlier. Then it can appear on X-ray chest. So yes, that is definitely better. And we have studies to prove that. Unfortunately, since, as I said, mine was a very basic question that whether oxygenation is affected or not. These all studies have been done prior, but this basic question was not answered in any of them.
Understood. So we are talking about oxygenation, but there are also words like lung compliance and resistance, which are often mentioned in your article. So the lung ultrasound score in your study demonstrated a strong negative correlation with the PaO2 by FiO2 ratio, but only a moderate correlation with the lung compliance and resistance. What are your thoughts on this result?
Basically, the compliance and resistance that we measure on the ventilator is very much dependent on the severity of the disease itself. But the one of the major factors is what ventilatory parameters you have set. So it will depend on the tidal volume, the amount of PEEP that you are giving, apart from the intrinsic pathology that the lung suffers from. So unfortunately, since it was an observational study and our ventilatory parameters may not have been precise, like for a particular severity, we did not adjust the PEEP, which would give the maximum tidal volume and vice versa. So that could have been one of the reasons why we got only a moderate correlation. And also, since we wanted to study the relationship between over a wide range of pathologies, so there were some patients who were just post-operative patients who were ventilated for excessive blood loss with absolutely normal lungs. So that could have introduced a bit of error as well. But since we wanted a wide range as we were studying the relationship, so maybe that could be the cause, and maybe a larger sample size with dedicated and controlled ventilatory parameters would eliminate this error.
So speaking of which, Dr. Nishant, how do you explain the variation in the lung ultrasound score cutoff for the PF ratio less than 200, which is 12 in your study, when you have compared with the other studies which have shown to be 17? How do you interpret the difference between your study and the other studies?
See, we limited our patients to a younger age group, number one. Number two, as I said, we had quite a range of patients. So ours were any mechanically ventilated patient, may not be with ARDS or with lung pathology per se. And we had eliminated all patients with an pre-existing lung pathology like COPD and all, which could have affected this score. So as I said, this was a very preliminary study. The other studies, if you study probably in sicker patients, like all patients with ARDS, you would probably find a higher cutoff value. But then this was just a very generalized study just to find the basis whether we can rely on ultrasound score for oxygenation or the severity of disease or not in the first place or not. So that was the basic idea of this particular study. And that could probably explain the lower cutoff in our study as compared to the other studies.
As you previously mentioned, this is a continuation of the previous topic. Like, your study included a lot of patients of various age groups and also varied surgical histories and different ventilatory modes. So how did these factors affected the results of your study?
Regarding oxygenation, I can say they wouldn't very much because the B lines would definitely be more or less and correlate with oxygenation. But yes, the pulmonary mechanics, the ventilator settings do have a role on what we see the pulmonary mechanics as, because the pulmonary mechanics are measured by the ventilator and it will depend on the ventilator settings. So as I said earlier, yes, I cannot for sure say that my results would apply to the pulmonary mechanics, but I'm pretty sure that if this study is replicated, the results for oxygenation would probably be the same. But as I said, this study needs to be done under controlled conditions for pulmonary mechanics, where we can control and maximize we can have the best pulmonary mechanics with the best ventilatory settings. So that is one thing that we did not adjust for.
So building on what you just mentioned, Dr. Nishant, could lung ultrasound score play a role in guiding weaning from the mechanical ventilation, or
Yes.
predicting outcomes like mortality or the length of the ICU stay? What do you think about this?
Yes, definitely, definitely. There have been studies which have shown that as the lung ultrasound decreases, the score decreases, the patient is getting better, the ventilatory parameters improves, the need for PEEP decreases, the oxygenation increases. So definitely it can play a role in deciding the ventilatory parameters also. As I said, in fact, when we were planning this study, we were told to have a temporal relationship between the patients and how the lung ultrasound would help us change our ventilator settings. But as I said, that would have entailed a much larger and a different primary objective altogether. But yes, future researchers can actually focus on this, and we can have a temporal relationship wherein we can follow a single patient for the time that he or she remains on mechanical ventilation, and see how the pulmonary mechanics, oxygenation change in the same patient over a period of time and with changing ventilatory parameters. So yes, that is food for thought for future research. And definitely, I think we'll have studies in the future which can predict morbidity, length of stay, and weaning from ventilation using lung ultrasound score.
Yeah. So let me wind it up by asking you, are there any specific lung conditions where the lung ultrasound score is, you feel less reliable for, guiding the treatment strategies?
Uh, in patients who have lung pathologies like COPD patients, elderly patients, it might be a limitation because they will have an increased number of B lines prior to the patient being admitted to the ICU. So the score may be falsely high. And I mean, again, this is a topic for further research, whether, as I said, we started from the very basics, taking we excluded the pre-existing lung conditions. But if the patient has certain like lung carcinoma or COPDs and pulmonary fibrosis, yes, that would definitely make a difference because they would already have a higher score. So we don't know how they would how reliable the B lines and lung ultrasound would be in those particular patients. So that is an entirely separate topic for study. So we'll have to see the lung ultrasound in those patients, have a similar research in those particular patients, and see whether the relationship between lung ultrasound, oxygenation, and pulmonary mechanics is there or not.
Thank you, Dr. Nishant, for sharing your thoughts. And we hope your study is a stepping stone for many further studies to come on lung ultrasound score. Thank you so much.
Thank you. Thank you so much. Good evening.
Over to Dr. Poornima to dive into the next article.
Thank you, Dr. Karthik. So, moving on to the next article. So, firstly, the article is going to be the 5-point airway or 5-air ultrasound protocol for confirmation of the endotracheal intubation and position in the pediatric patients undergoing surgery. It was a prospective observational study. Today, we have the author with us, that is Dr. Zainab Ahmad, professor in the AIMS Bhopal. Madam, welcome to the podcast, firstly. We are excited to have you here, and we're going to know about your research, and we shall dive in deep and know about what the protocol was, how your real-time implication about this protocol will be, and how we can imply this into the clinical setting. Welcome, Dr. Zainab. And
Thank you, Dr. Poornima. And first of all, thank you, Dr. Rakesh, Dr. Gayatri, Dr. Karthik, and the entire team at IJA Podcast for having me here today.
welcome, ma'am. We are also glad to have you. We'll quickly dive into this research of yours. To start with, Dr. Zainab, could you walk us through how this 5-air ultrasound protocol came into its origin? And can you share with us the research journey and how it led to the development of this particular article that you have encountered?
Okay. So, first of all, I would like to tell the listeners that the 5-air ultrasound protocol is a comprehensive ultrasound protocol for assessment of endotracheal intubation. So, here we are assessing the usual two things that we are assessing while doing an endotracheal intubation. So, one, whether the endotracheal tube is correctly placed or not, that is, it is esophageal or tracheal. And second, whether the endotracheal tube is correctly positioned or not. So, that is whether it is endobronchial or tracheal. So the 5-air ultrasound protocol, it involves 3 steps. Step 1 is the real-time tracheal ultrasonography, which is performed simultaneously during intubation, in which we look for the ultrasound signs in real time. So confirmatory signs include the snowstorm sign, the bullet sign, and the absence of the double track sign. These signs are all detailed in the article that we've written. Okay, so in the first step itself, we confirm whether the tube is in the esophagus or in the tracheal. Once we've confirmed that it is in the trachea, we move on to the next 2 steps, which is sequential bilateral pleural as well as bilateral diaphragmatic scanning for visualization of the visceroparietal pleural interface movement, that is commonly known as the lung sliding sign, and bilateral diaphragmatic scanning for visualizing the craniocaudal diaphragmatic movement. So, the step 2 and step 3, they confirm whether the endotracheal tube is endobronchially or not. So, the idea for this protocol, it stemmed from the clinical difficulty that we often face, especially in smaller children, in which sometimes it is difficult to really assess whether the tube is endobronchial or not, and sometimes even if it is esophageal or inside the trachea. So, in small pediatric patients and really obese patients with thick chest wall, when there's absence of good breath sounds, so in these patients, the 5-point auscultation may be equivocal. Then again, what happens in low flow states? For example, there's a cardiac arrest or there's a pulmonary embolism. Already the capnography is going to be limited. So we felt that in certain cases, both auscultation and capnography is unreliable. Then having looked at literature, we found a high rate of endotracheal tube malposition in pediatric patients. There was a very high rate of endobronchial placement reported in the literature, about 40%. And we also found that no comprehensive and systematic ultrasound protocol has been described as yet for intubation. A lot of researchers are using different signs, but there is no comprehensive and systematic airway ultrasound protocol. So we designed the 5-air ultrasound protocol to mimic the 5-point standard auscultation that we use. And it also integrates all the few ultrasound signs that we found that will be useful into a comprehensive whole. So that is how we decided that this will be the protocol and this will be the steps. These are going to be the steps of the protocol.
Okay, thank you, Dr. Zainab. That was a very straightforward approach that you went through with this protocol. So knowing that this protocol was in a very well-validated, controlled setting, and especially in the elective cases with experienced operators, how would you adapt this in real-world emergency situations, and especially when these situations are encountered with varying levels of expertises? So how would you adapt this?
So yes, that is an important caveat. We did validate this protocol in control setting. We also made sure that the persons conducting the study, the persons conducting the protocol, they were trained in about 25 patients prior to commencing the study. So there is of course going to be a learning curve, and as in all the ultrasound, all the POCUS applications, there's a learning curve involved, right? So a learning curve is going to be there. But once the practitioners gain enough experience, we believe that the accuracy rates will mimic the control settings. Of course, they will not be exactly the same, but slowly they'll get better. It is analogous, for example, lung ultrasound or USG for vascular assessment that is often used in the ICUs. So initially there were a lot of concerns with accuracy, but after a lot of validation studies, they have been found to be accurate, and use of ultrasound in the ICU is ubiquitous now for a lot of focus settings. In the operating room, I feel that penetration of ultrasound is limited to vascular and regional anesthesia applications. And for rest of the focus applications, penetration is still limited. So once we gain more experience, ultrasound availability is there in most of the operating rooms. I feel that in uncontrolled settings also, for example, in emergencies and difficult airways, it will help. But of course, studies have to be there. We've just conducted this study in non-emergency patients and in non-difficult airway patients. So we don't know for sure, but we assume that it is going to be helpful in emergency cases because these are the cases in which more help is required. We will have trouble with auscultation. We might have trouble with capnography, as we discussed earlier. So these are the conditions in which focus and airway ultrasound will be more useful. So that is why we believe that the 5-wire protocol will be useful in emergency settings, and especially due to its speed and its high sensitivity. But of course, a learning curve is going to be there. So we have to tackle that as well.
Yes, ma'am. So as you were talking about the learning curve, what do you say? How many cases do you think is mandatory to do before someone can be expertised in performing this ultrasound confidently in a both elective and an emergency situation?
So while we've not explicitly researched this fact, this aspect of the 5-wire protocol, but in our study, we made sure that our operators, they underwent hands-on training on 25 pediatric cases before commencing the study. So though we've not researched this, but the data suggests, and there's a lot of literature which says that about it has a moderate learning curve. So about 25 to 30 patients is sufficient to gain sufficient skill. And there are a lot of studies on other focus applications, and most of the studies, they say about 25 to 30, 25 to 30 events or cases is sufficient for the practitioners to gain enough skills. Also, we believe that the young postgraduates, they are being exposed to ultrasound right from the first year itself, right?
True.
So we have been exposed to focus and ultrasound a lot later in our career. So I feel that it is much easier for them to quickly pick up focus skills. So that is why we believe that it doesn't have a very steep learning curve. Having said that, we don't have hard evidence yet to support this evidence, and maybe this could be a direction for future research.
I agree with you, Dr. Zainab. I think the exposure to focus and the ultrasound inside the operating theaters have been much more in a faster path forward lately compared to what it was in the past. Moving on, so in your protocol, there was a requirement to switch the curvilinear probe, especially in older patients or a little obese children. So in this way, what do you think in cases of a critical situation or a critical case or an emergency, the switching over, how do you think it will impact in that particular cases?
Yes, so this was an issue of concern. So switching the probe from a linear to a curvilinear probe, which was required in about 47 patients, it took about 19 seconds extra. So taking the protocol to about 30 seconds. So in control condition, it may not be so much of a problem, but yes, in emergencies where every second counts, it could be an issue. But in newer and advanced machines, there is now an electronic switch in which by which we can simply switch between the different probes. So as we are steadily, harnessing better technology, we have better machines coming into our operating room. The technology is getting cheaper. So once we have those those machines with electronic switching between the probes, it will be much easier, and this problem will be taken care of. So until then, I would say that yes, it is a problem. So in emergencies, if you have a basic machine in which manual switching is required, those extra 20 seconds are going to be lost.
Okay. Moving on, ma'am. In your study, there was no esophageal intubations. And if someone had to encounter this and they had to quickly pick it up in a critical condition, how do you think they can be confident by using this ultrasound? How will they go forward knowing that your study did not mention any of these esophageal intubations?
Yes, you're right. So this is one of the limitations of our study. And we cannot really comment on the ability of this protocol to detect this specific complication as a whole, the protocol as a whole. But yes, because transtracheal ultrasound is now quite common, and a lot of studies have already shown that transtracheal ultrasound by itself is highly sensitive and specific in diagnosing esophageal intubation. So just the esophageal intubation part, we are pretty confident that once the learning curve is achieved, the operator can easily diagnose an esophageal intubation, even though our study directly does not comment on this fact. But tracheal ultrasound is going to be important, and it's going to be a necessary skill to learn because uh, most of the studies show that it is highly accurate in diagnosing esophageal intubations.
Okay, ma'am. So as we wrap this up, I have two more questions to ask you on this. So we know that capnography has been a gold standard for a long time now and is going to be or not. So what role do you think this ultrasound can play, whether it will replace or it will supplement the current confirmation methods that we have for finding out the endotracheal position and intubation?
So I think it will be one of the, one more tool in the armamentarium of anesthesiologists to diagnose esophageal intubation and to diagnose endobronchial intubation as well. So capnography, as of now, it remains the gold standard. And with the current evidence and technology, we can say that the 5-Air protocol will supplement capnography. We're not saying that it will be able to replace it. But yes, if capnography is equivocal or if it is unavailable for some reason, then the 5-Air protocol will prove advantageous and may especially be helpful in those situations. So the 5-Air protocol, we believe that it can supplement capnography. And as earlier 5-point auscultation was there as a standalone technique to confirm intubation, right? Then
Yeah.
After a few years, capnography was introduced and made a mandatory part and a standard of care. In fact, it is the current gold standard. So similarly, we believe that airway ultrasonography will also come up in a big way, and it will supplement the existing methods for confirmation of endotracheal intubation.
Okay, ma'am. And lastly, to cover this, I wanted to know how your protocol can be implemented in difficult airways. Can it add to the workflow? Can it be included into the algorithms? How do you think your protocol can supplement to the difficult airways at current situation?
So though in our study, we excluded difficult airways because this was the first study that we conducted using this protocol. But we saw during the conduct of the study, the transtracheal ultrasound can actually help in directing the endotracheal tube towards the trachea. So suppose it is hitting the esophagus when the visualization is not clear. So suppose the endotracheal tube is hitting the esophagus or it is tightly going towards the esophagus. So without starting ventilation through a wrongly placed esophageal endotracheal tube, we can actually diagnose an esophageal intubation. And we can also, cut it short. So that attempt can be cut short if the tube is going towards the esophagus. Another situation in which it might help is sometimes due to bronchospasm or due to repeated attempts, the air entry we get is often limited. So in this situation, auscultation may be impaired and the ultrasound protocol may be useful in both these situations. Also, for example, when we're using video laryngoscopy versus direct laryngoscopy. So in video laryngoscopy, the assistant is also able to visualize, right?
Yes.
And is able to help. So similarly, when we have the ultrasound at hand, the assistant, whoever is there, the staff and whoever is the assistant, that person can also visualize whatever is going on, visualize whether the tube is inside or not. So that is why we feel that it may be able to help in difficult airway scenarios. Again, this is a direction for future research because we have not specifically tested this protocol in difficult airway situations.
Yes. Dr. Zainab, you have very patiently shared your incredible insights about this protocol with us. And I'm sure this 5-Air protocol is going to supplement into the airway management in the pediatric group of patients. Thank you so much for being with us and sharing this along with us. And I wish you much more good luck in more research that you can bring about in the pediatric airway anesthesia. And moving on, I will hand over to Dr. Karthik. Dr. Zainab, would you like to say something to end this?
No, just my thanks. Thanks, Dr. Poornima, Dr. Gayatri, Dr. Karthik, and Professor Rakesh sir, who's always been, he's been encouraging in all our endeavors. And all the best for your for this podcast series. Thank you so
before
much.
you end, Dr. Zainab, can you just release some good research question on this area for listeners? Because you have done some good research. So what do you think few research questions can be there for future researchers that further validate the usefulness of your good research?
So, sir, we wanted actually to carry this research forward and we wanted to compare the value of this research in different situations. For example, in difficult airways, then in patients in emergencies. We also wish to see what the learning curve is, because everyone doesn't learn at the same speed. So even I, because I was introduced to ultrasound late, I find it a bit difficult than my residents. The residents, they catch it really easily. So sometimes we have to learn from the juniors, and I feel that learning curve is a big lacuna in our Indian scenario, because most of the studies that I've seen are international studies on learning curve. So though it is slightly tedious to do a study on learning curve, but I think that is an exciting area that we can work on.
Thank you so much, and all the best for doing good work. I personally know you. You're a wonderful researcher and academician. Thank you so much for joining.
Thank you,
And
sir.
back to
Thank you
Dr.
so much.
Poornima and Dr. Karthik.
Well, thank you, Dr. Zainab. Moving on, the next article we are about to discuss is transnasal humidified rapid insufflation ventilatory exchange, also called as THRIVE, a game changer in apneic anesthesia for shared airway procedures. It was a retrospective study. Sharing their expertise with us, we have Dr. Minal Harde, who is a professor, Topiwala National Medical College in Mumbai. Hello, Dr. Minal. Glad to have you here today.
Good evening, everyone, and thank you very much, Dr. Karthik, Dr. Rakesh, sir, and whole IJA team. And thank you very much.
Ma'am, actually, this will be a good topic of interest for all the postgraduates, because it is often being asked in the examination paper these days in the university exams. So, to begin with, ma'am, can you briefly explain what is apneic oxygenation and how does it differ from pre-oxygenation, and also a small word about what is safe apnea time?
As we all know, maintaining oxygenation and prevention of hypoxia at all times is our highest priority as an anesthesiologist. And pre-oxygenation, like we have been doing since years, is a standard technique done prior to anesthetic induction in tracheal intubation, which is basically denitrogenation and is helpful in delaying desaturation during times of apnea. And apneic oxygenation is providing oxygen supplementation during apnea using nasal cannula catheter, which further extends the safe apnea time. Now, combining pre-oxygenation with apneic oxygenation further increases the safe apnea before actual desaturation starts. And we can use low-flow devices for both pre-oxygenation as well as apneic oxygenation. But using high-flow oxygenation techniques like HFNO, which is high-flow nasal oxygen, or THRIVE, which is transnasal humidified rapid insufflation ventilatory exchange, they provide additional extended safe apnea time. Now, safe apnea time is considered time in minutes till oxygen saturation is maintained above 95%, or apnea time without desaturation or excessive hypercarbia. And various studies have given a wide range of safe apnea time, right from 14 to 65 minutes using THRIVE.
Thank you for sharing that, Dr. Meena. Since we have spoken about safe apnea time, now can you tell us about what is apneic anesthesia and what are the surgical procedures which would require this apneic anesthesia technique?
Now, tubeless apneic anesthesia is a specialized technique which is used in certain shared airway procedures where surgical access is not possible with endotracheal tube. As we all know, endotracheal tube is the gold standard technique. However, certain procedures like microlaryngoscopy, laryngotracheobronchoscopy, rigid bronchoscopic procedures, tracheal dilatation for tracheal stenosis, tracheobronchial foreign body removal, lesions on the posterior cord, vocal cord, or posterior wall of trachea, then certain bronchoscopic procedures for intraluminal lesions or carinal lesions, wherein endotracheal tube and surgery is not possible. In these procedures, we have to provide apneic tubeless anesthesia.
All right. So, your study calls THRIVE a game changer in the shared airway procedures. Could you begin by telling us what is THRIVE and also how it differs from the conventional oxygenation techniques in apneic anesthesia? Or in other words, what specific benefits did you find over the conventional methods compared to THRIVE?
So apneic anesthesia can be provided with various conventional techniques which we were using like regular oxygen supplementation using nasal catheter, cannula, or intermittent mask ventilation by interrupting the surgeon, or intermittent tube intubation and ventilation and tube out technique, or commonly used jet ventilation. While all these techniques have certain limitations like very limited apnea time resulting in early onset hypoxia, hypercarbia, which requires repeated surgical interruption for ventilation, airway trauma, then jet flow causing surgical field vibrations and tissue debris being blown into the lower airway, or high pressure complications like pneumothorax, etc. Now, Thrive is a recent entry into our armamentarium, and we call it a game changer for tubeless apneic anesthesia, as it provides heated humidified oxygen at very high flow rate, that is 20 to 70, which is higher than our inspiratory flow demand or PIFR. And as compared to low flow techniques, which are variable performance, Thrive has fixed patient independent performance, and it provided extended uninterrupted safe apnea time with an unobstructed surgical field, reducing surgical and anesthesia time because there were no interruptions in between for ventilation and without any complications. And that is why we did call it a game changer.
That's quite an interesting perspective, Dr. Meena. While I was going through your study, one of the key concerns during the apneic anesthesia is carbon dioxide washout or carbon dioxide clearance. So the highest value for the EtCO2 at the end of apneic anesthesia, in your study, it was 55 millimeters of mercury, which, as you mentioned, normalized within 1 to 2 minutes of ventilation. So could you explain the physiological principles behind Thrive, such as how it maintains the oxygenation and how does it facilitate, washout of carbon dioxide?
Yes. There are multiple mechanisms of gas exchange during apnea using Thrive. I would like to mention few, like high oxygen flow creates pharyngeal oxygen reservoir called as supraglottic flow vortices, which also extends to the distal airways, resulting in improved gas exchange. Oxygenation is maintained by high alveolar oxygen content, facilitating exchange due to concentration gradient. It is also called as aventilatory or hypoventilatory mass flow or apneic diffusion of oxygen. And CO2 clearance occurs due to microventilation via cardiogenic oscillations and gas mixing in the anatomical dead space with high flow. In addition, there is flow-dependent CPAP, which maintains the airway patency and prevents airway collapse, washes out dead space. And thus, Thrive can be effective in delaying hypoxia for a prolonged period and to some extent hypercarbia during the periods of apnea. So in our study, we did observe around 15 minutes of apnea with Thrive. There was no desaturation and minimal hypercarbia, which normalized immediately after few breaths of ventilation. That is what we did observe.
Okay, thank you for clearly explaining that. It actually makes a lot of sense now, doctor. So, how was the EtCO2 monitored during your study? Did you encounter any technical challenges in getting the reliable EtCO2 measurements, and how did it correlate with the arterial blood gas values? Seeing that in some of the patients you have done blood gas sampling also. So how was it relatable?
Being apneic anesthesia, EtCO2 cannot be measured continuously. So oxygenation is maintained for a prolonged period, although with Thrive, and there is known CO2 clearance mechanism, but we did observe a steady slow rise of CO2 over time, and which has also been mentioned in other studies. And that is why we were, extra vigilant. And this with adequate oxygenation, which is being maintained with high flow oxygen, moderate hypercarbia is tolerated very well under apneic conditions. However, limiting apnea time is essential in spite of oxygen saturation being maintained. That is what we also practiced. And we did ABG monitoring in certain patients, not all patients, wherein we found that the apnea time is getting extended, or we were being extra cautious because we were also using it, we got this Thrive during COVID times, and after that we started using it. So to check for the CO2 levels on a safer side, we did venous sampling or arterial sampling in certain patients. And we did after about 15 minutes in most of the patients, either the procedure got over or we did ventilate. And at that time, we observed there was minimal rise of ETCO2, minimal to moderate, and which normalized within a few breaths of ventilation, and it correlated well with the arterial sample at that time. Some studies have even mentioned continuous transcutaneous CO2 monitoring. However, we did not have that. And hence, limiting apnea time is essential.
So adding on to it, Dr. Minal, your study included patients across a wide range of age groups, like 2 to 84 years. So could you share your experience about adapting the technique across the various variable age groups? And did you have to make any modifications, especially for the pediatric cases?
Yes, we did use it in a wide range, and much of modifications not required. In all extremes of ages, we ensured utmost preparedness and open communication with surgeons, all the alternate backup plans for maintaining oxygenation and ventilation, such as microlaryngeal ETTs of all sizes, supraglottic airways, FOB, JET, and tracheostomy tubes were kept absolutely ready. In pediatrics, we did use lower flow rates, like starting from 4 liters per kg. And a majority of the pediatric cases which we did were foreign body aspirations, which were done in a very short apnea time of around 12 minutes, and only few required extended apnea time.
There is no like any procedure or technique without any risks or complications. So what are the potential limitations or risks associated with Thrive, particularly if the procedure is getting extended? And what was your strategy of ventilation when the procedure extended beyond the safe apnea time?
Yes. Majority of the procedures were done in the single apnea time of approximately 15 minutes. However, out of 60 patients in 8 patients, the surgical duration and apnea time was exceeding beyond 18 to 20 minutes. And hence, we did mask ventilation in 4 patients during the instrument changes when surgeons were changing the instruments. We had that window and we did mask ventilate and monitored the ETCO2, normalized it, and then again handed over to the surgeon and continued with the next apnea time. And in 4 patients, since suspension laryngoscopy apparatus was already in situ, so putting a tube by the surgeon was very easy rather than removing the whole apparatus and mask ventilating. So we did intubate in those 4 patients, ventilated for few breaths, and then again removed the tube, and surgeons continued with their procedures. And I would like to mention that none of these patients we did ventilate because of desaturation. None of the patient had desaturation, but only to be extra cautious and not to avoid any excessive CO2 rise, we did ventilate at that particular time. So, and after that, we could resume the apnea and continue with the procedure. That is what we practiced in extended procedure.
You actually answered my next question, like what would be the potential risks? Because your study had no complications like what is written in the article. So what anesthesiologists should be vigilant other than desaturation or hypercarbia? Is there anything else you would like to add on?
Since this is a high flow but low pressure technique and provides heat humidification, there are no serious complications associated. And it is a very simple device to use. However, few possible complications may include like nasal discomfort in the post-op period, unrecognized and untreated hypercarbia, as I already mentioned, gastric insufflation may occur, aspiration and post-op nausea, and there might be theoretical risk of airway fire during laser surgeries. Although we did not observe any of it, but it is best to be vigilant and use preventive techniques to minimize these, like we did use anti-silovog and neck extension with head down tilt to allow suction of blood and secretions, deflated the stomach at the end of the procedures, and limitation of apnea time, as I repeatedly stressing, is highly advisable.
Thank you for sharing that, Dr. Minal. This brings us to my last question. What other clinical scenarios have you found Thrive beneficial for, like which you often do at your institute, or where you have felt it's really a boon?
Yeah, so Thrive is definitely a valuable addition to our airway armamentarium and highly useful in perioperative period as well as in the ICU and recovery area. We use it for pre-oxygenation, for peri-oxygenation during difficult airway and awake intubations as well. Procedural sedations, especially in GI endoscopy suite, wherein you cannot actually interfere with the surgeons too much. Therein, the Thrive also has inbuilt ETCO2 cannula for continuous monitoring. Then can be used post extubation. Then in the recovery area, in ICU, we may use it for early respiratory failure to, avoid or delay intubation, or as an adjunct to non-invasive ventilation and weaning from ventilation. We may, adjust the flow rates as per the patient's requirement, and has wide range of use in perioperative as well as ICU. And we are still, using it as and when possible for apneic anesthesia.
Thank you so much for sharing your valuable insights, Dr. Minal.
Very
Any
much.
final words from Dr. Rakesh, sir, Dr. Gayatri?
Madam Gayatri.
So I'm just waiting here to wish everyone a happy Christmas. And I'm really excited to see what the new year brings for all of us and the IJA.
Thank you, madam. I think quite interesting topics, and there would be many interesting topics coming in January of high quality articles from researchers across the world, and few more surprises that will be coming through IJA from the academic forum, from the research forum. Keep looking towards it. IJA is going to release its reviewer portal soon. So those who are interested to become the reviewer of IJA, they can join the IJA portal. The link will be shared on various platforms. And another good news, IJA is also releasing. It's almost finalized with the IJA editorial fellowship, and the details will be shared it's almost finalized, so it will be shared within a week. Those who really wants to join and learn some of the editor work, they can join the IJA editorial fellowship also. So thank you so much, and thank you especially to the IJA port, Dr. Murli, Dr. Gayatri, Dr. Karthik, Dr. Poornima, for all the hard work to make the podcast informative source for learning, and we learn each time. Thank you so much. Over to Karthik.
All right. Well, on that note, a huge thank you to our wonderful authors for sharing their insights. And of course, to all the amazing listeners for tuning in today. As we wrap up the year, here is wishing you all a very happy new year and a prosperous new year. And speaking of the New Year's resolutions, ours here at IJA is to keep bringing you even more valuable, more innovative, and more path-breaking research articles in the coming year. Until then, stay safe, stay curious, and we'll see you in the next year with another fascinating discussion. Do not forget to subscribe to the channel and click the bell icon to get notified of the next video. Take care.